Welcome to the Deep Dive. Today we're tackling high blood pressure, but maybe not the kind you're most familiar with. Most people know about essential hypertension, where the cause is a bit of a mystery.
Right, the vast majority.
But we're digging into something called secondary hypertension. This is where high blood pressure is actually caused by something specific, something identifiable.
Yeah.
Like finding a hidden switch.
And, that difference is just so important for you listening. Primary hypertension, yeah, that's about 90% of cases.
The usual suspect.
Exactly. But the secondary type, maybe only 10% in adults, but finding it is crucial because the underlying cause, it can often be treated, sometimes even cured.
Cured. That's a huge deal for blood pressure.
It really is. Imagine, for a condition this common, finding a curable reason in, say, 1 out of 10 people affected. It changes everything. We're talking root cause, not just symptom management.
Okay, so yeah, it shifts the whole picture from just managing it forever to maybe fixing it. So how do we even start suspecting this? If we're putting on our detective hats, what are the clues, the red flags?
Good question. Yeah, we look for specific clinical signs, things that suggest, hey, maybe there's something else going on here.
Like what?
Like getting diagnosed really young, say under 30, maybe 40. That's unusual.
Huh?
Or if the high blood pressure comes on very suddenly, or it's extremely high right from the start. Another big one is what we call resistant hypertension.
Meaning it doesn't respond to treatment.
Pretty much. Your blood pressure stays high even though you're on 3, maybe more different meds at their maximum dose. That should definitely trigger a deeper look.
Right.
And here's one that might seem unrelated. Unexplained low potassium levels. That can point towards an issue with the adrenal glands.
Low potassium. Interesting. Wouldn't immediately connect that. But, okay, before we jump into all the complex tests, is there something simpler we need to check first?
Yeah.
You mentioned something about measurements.
Absolutely. Before ordering a battery of tests, you have to rule out what's called pseudo-resistance.
Pseudo-resistance, so fake resistance.
Sort of, yeah. It means the reading is high, but maybe the actual blood pressure isn't quite as bad as it looks, or there's a simple reason it seems uncontrolled.
How does that happen?
You'd be surprised. The classic example is the blood pressure cuff size. Just using the wrong size cuff can overestimate your pressure by, get this, up to 17 millimilli Hg.
Wow, 17 points just from the cuff.
It's significant. Then there's white coat hypertension. Blood pressure is high in the clinic, maybe due to nerves, but it's perfectly fine when you measure it at home.
The doctor's office effect.
Exactly. Or sometimes it's simply about adherence, making sure medications are actually being taken as prescribed. So job 1 is confirming the pressure is genuinely high outside the clinic setting.
So step 1 isn't always more tests, it's better information. Makes sense. Okay, now, you mentioned things like kidney issues, adrenal glands. It sounds like a lot of these different causes might be linked somehow.
They often are. There's a central player involved in many of these cases. The renin-angiotensin-aldosterone system, RAAS for short.
RAAS, okay, what does that do?
It's basically a hormone system your body uses to regulate blood pressure and fluid balance. Crucial stuff.
And how does it connect to secondary hypertension?
Well, conditions like renovascular hypertension, that's a narrowing of the arteries going to your kidneys, or even obstructive sleep apnea, OSA.
Sleep apnea? Really?
Oh, definitely. OSA is incredibly common. It affects something like 40% of people with any hypertension, and maybe up to 90% of those with that resistant type we talked about.
90%, wow.
Yeah. And both narrowed kidney arteries and OSA can basically activate this RAAS system, which then drives up blood pressure.
Okay, I see the connection.
And here's an interesting twist related to RAAS. Some common blood pressure drugs, the ones that block RAAS, they can actually make kidney function worse if you happen to have narrowing in the arteries to both kidneys. So a sudden jump in creatinine levels, that's a marker for kidney function right after starting one of these drugs. That can actually be a clue to the diagnosis.
Huh. So the treatment itself can reveal the underlying problem. That's complex. We've covered some big flags, measurement issues, this RAAS system. What about simpler things? Are there clues just from, say, a physical exam?
Definitely. A good physical exam can tell you a lot. For instance, checking blood pressure in both your arms and your legs.
Arms and legs. Why?
If there's a big difference much lower in the legs, it could point to something called coarctation of the aorta. It's a narrowing of the main artery you're born with.
And that causes high blood pressure.
Yes, often in the arms. And the good news is it's often fixable with treatment, potentially curing the hypertension.
Amazing. What else?
Even simpler. just looking carefully at your medication list. Over-the-counter stuff counts too.
Like what?
NSAIDs are common culprits, non-steroidal anti-inflammatory drugs like ibuprofen or naproxen.
People take those all the time.
Exactly. They can raise blood pressure on their own, and they can make your blood pressure meds less effective. It's a double whammy.
Sneaky.
And don't forget lifestyle. For someone who drinks heavily, quitting alcohol can lead to a noticeable drop, maybe 5.5 points systolic on average.
Right. Simple, but powerful.
Bro.
Okay, so wrapping this up, what's the big takeaway for you listening?
I think the main thing is that secondary hypertension, while less common than primary, is really important not to miss.
Because it might be treatable, even curable.
Precisely. It means there could be a specific reason for your high blood pressure, not just bad luck or genetics. It highlights the need for a careful, step-by-step approach, starting with the simple things like checking measurements and meds.
It's not just about the numbers. It's about the story behind them.
Exactly. Understanding these possibilities, recognizing these flags. It's not just, medical facts. For you, it could mean getting the right diagnosis, the right treatment, and honestly, a much better outlook for your health.
So maybe the question to leave you with is, could there be more to your blood pressure story? And are the right questions being asked to find out?